Welcome to Section 3 of the Introduction to Pharmacology. In Section 3, we'll be talking about properties of drug-receptor interactions, which is going to be some really basic chemical bonds and things like that, but then it's going to build up into some actual charts or graphs and some theory behind really how receptors will bind to drugs and how that looks on a dose-response curve. And again, that last point is really called dose-response theory. So this is going to be pretty quick. I don't want to spend too much time on this because you've already seen all this in chemistry and maybe some other courses. So drug receptor binding, it does depend on multiple types of bonds, and we're going to go over briefly in the next few slides, kind of like the fact that each bond has a different distance within which it will have some effect. But for this slide, we're going to talk about the bond strength. As you probably would recall, covalent bonds are going to be stronger. You don't have to memorize the actual bond energy here, but please understand the actual rank order and what's the strongest all the way down to the weakest. So covalent bond, that, believe it or not, that does happen with some medications. Some medications are chemically interacting with the receptors, and that can be permanent. And permanent is always kind of like I would say, dangerous word to use, because these can be reversed if the receptor gets destroyed or internalized and recycled. So they're permanent for as long as the receptor survives, for the most part. That is not always a desirable characteristic. It depends on the drug and depends on the purpose. For example, Prilosec or omeprazole, that binds to the proton pump for almost 24 hours. It's actually permanent until the pump gets recycled. And then chemotherapeutic drugs can bind to DNA, and that's pretty much permanent. Next is ionic bonding. Ionic bonding is a little weaker, but it happens at a longer distance. So this ionic bond it's good at the initial attraction when a drug is not right next to the receptor, but it's somewhere near. It's getting closer. The ionic bond will take place in that case, and that's of course between a negative and a positive charge. So the negative charge could be on the drug, or the negative charge could be on the receptor. It just depends on the situation. And again, most receptors do have ionizable functional groups, and hopefully that makes sense to you, because receptors are made mostly out of amino acids, right, or proteins, which have many side chains which can be positively or negatively charged. So again, examples would be carboxylates would be negative. That's the most common example. Or an amine would be, if it's got 4 bonds, then 4 total bonds, it's going to be positively charged. Hydrogen bonding is next. And of course, that's between particular elements. The most common will be hydrogen and oxygen, but then there are just a few other ones that we have here. The bond energy is slightly weaker, maybe, than an ionic bond. But the important point to note here is that some drugs will bind with multiple hydrogen bonds, and that will the collective strength will increase anyway, even if a single bond isn't very strong. Okay, and really, the closer a drug gets to the receptor, whatever bonds are starting to occur at that close vicinity, those are more important for the selectivity. Whereas like for instance, the ionic bonds, they happen at a pretty far distance, and pretty much every protein is going to have some negative charges and positive charges. So every single drug might have a weak affinity for most proteins or most receptors, and that's going to draw them in. But then when the drug gets closer, what really solidifies that bond is going to be really the hydrogen bonding, and then the van der Waals bonds. And then the first one, covalent, again, is not that common, but it does happen with some drugs. So really, the hydrogen bonding and the van der Waals forces are really, really critical for selectivity, and that's usually a test question. So it's really important to understand that. So the van der Waals bonds are, and I'm not going to go over exactly how they work again, because you learned that in chemistry. Again, they're fairly weak as with a single one, but then when you have multiple van der Waals bonds, they can be much stronger. And then there are a bunch of other kind of smaller or less commonly discussed types of bonds that I'm not going to get into, but you can get into some details about, is it a nonpolar interaction? Is it a polar interaction? Sometimes you have aromatic groups stacking on top of aromatic groups in a protein. So there are a lot of other types, and in many cases, drugs will have multiple important bond types. Something that I'm not going to spend too much time on this. After this slide, I probably won't mention it too many times, but it's something I want you to be familiar with. The biophase. This is an important definition, important term. That's the area of solution or fluid surrounding the receptor. And the reason why that's important is because the receptor surrounding area around that receptor is going to have potentially different characteristics than the bulk fluid. For instance, if we're looking at a smooth muscle, maybe the interstitial fluid would have certain pH, certain electrolytes, but then if you get closer to the receptor, that may actually change, and that's why it's got its own name. That's called the biophase. And drugs move randomly in that biophase through Brownian motion. And as I mentioned, drugs are initially attracted through ionic bonds, and then when it gets closer, then you have the hydrogen bonds and van der Waals bonds, and in some rare instances, the covalent bonds. And since this is going to be important to know, and that's why I have it in bold at the bottom. Once a drug binds to a receptor, if it's not covalent, it has the ability to be, it's going to be reversible. So the drug could bind and then come off, and then bind and then come off, and that's going to be important to understand that that's not the end point. Once a drug binds, that's not the end of it. It can come off, and then the drug could diffuse away. Another drug molecule can come in. It could be the same exact drug, but just a different molecule coming in then binding to that receptor. Okay, so that will be important when we talk about receptor theory. So this is just a summary. First we have ionic bonds. Okay, and that is a pretty far distance. Please don't try to memorize the exact distance, but it's going to be a farther distance. And then when we get closer, what gives that really strong affinity at the end, which is the affinity is just the strength of the interaction and how strongly it binds. That's going to be through the hydrogen or van der Waals forces. So hydrogen. So this is a kind of an older image, but I think it helps to illustrate the point with respect to the different types of bonds. So these circles with TM are just the transmembrane regions of one of those 7 transmembrane spanning G protein coupled receptors that we talked about. So these are just pieces of the receptor, but this is like a top-down view, like an overhead view. If you were looking down like on the outside of the cell, looking in, this would be one receptor on the plasma membrane, and we kind of cut it in half. And if we look at where the drugs are binding, in this case, in green here would be a drug molecule or an endogenous ligand. Okay, in the red would be one type of bond, and then in the kind of pink here or purple, depending on how you see it, that's going to be a different type of bond. So why don't we start with that green kind of purple or pink. That's going to be the amine from the drug or ligand is binding with the carboxylate on this TM or transmembrane region 3 of the protein or receptor. If you look at the red here with the green, that is more of a van der Waals interaction. It might even be considered aromatic stacking or nonpolar. But essentially the whole point is that it is kind of a carbon-carbon interaction. So it's not an ionic bond, it's not a hydrogen bond. Okay, and then finally we do have a hydrogen bond over here, and of course the hydrogen would be interacting with the oxygen, not the H with the H, even though it looks like that here. So all these together is what makes a drug bind to only one or a few receptors, right? So there might be another receptor in the body that this drug or molecule binds to, but maybe it only binds with just the hydrogen bonds. And in that case, it might not bind at least strongly enough to give us a biological response. So the reality is, though, almost every drug you could think of will have some non-specific bindings to some receptor that we probably don't want it to bind to. And that's important to understand, and that's one reason for side effects, and not the only reason. So I mentioned affinity, but if we want to actually kind of mathematically define that, it would actually be the amount, well, just to summarize, it's basically the amount of drug bound to the receptor compared to the amount of total drug available. And let's just look at this equation here to make sense of that. So the L in the brackets here would be the ligand concentration or the drug concentration. And it could be endogenous. It could just actually be epinephrine or an any endogenous molecule that binds, which is called a ligand, that'll bind to the receptor. The receptor concentration, and these are separated on the top because that means free ligand and free receptor, and they're not bound to each other yet. However, if we look in the bottom of the equation, that's the LR complex. That's the ligand receptor complex. So what all this equation is saying is that if we take on the top the free ligand times the free receptor, divide that by the complex, or the concentration of the complex, we get something called a KD. And hopefully you can quickly look at this and say, well, if the ligand really likes to bind to the receptor, I should find more LR complexes and less free ligand and less free receptor. So that would actually give the denominator a higher value, which would lower the KD. So this is a little bit opposite. Well, it's definitely opposite of what you would, intuitively maybe want to think. But KD is essentially, right, the lower, the higher the affinity. Right, lower KD means higher affinity, believe it or not, and that's because of this equation. Okay, even though it actually could be more convenient to use a Ka, that would go then in proportion to affinity. So higher K would be higher affinity. For some reason, the convention is to use KD, so lower is better if you're looking for high affinity. So now, in reality, it's extremely hard to measure the exact number of complexes in a real experiment. Okay, and there are other ways to find KD that we'll talk about. There's a really easy way. So again, affinity has a chemical meaning. It's unique to the ligand receptor pair. That means you can't just say that a drug has a certain affinity. You have to say a drug has a certain affinity for a specific receptor, and you have to identify the receptor in the drug. And again, you can't just say that a receptor has its own affinity. It's always the pair, the drug-receptor pair has a specific affinity. It's very critical to understand that it describes only the strength of the interaction of the ligand with the receptor. It doesn't tell you anything about the biological response. So something could be extremely high affinity for a receptor, but do nothing. Once it binds, it could do nothing to the receptor. It may not activate it. It may inhibit it or do nothing, and that would be many drugs on the market, right, are inhibitors, and that's what they do. They bind, so they have affinity, but they don't really do anything after that. Okay, so KD describes the ability of a ligand to bind a receptor and is a measure of affinity. So sometimes I'll use these interchangeably. So if I say, tell me the affinity, you would tell me the KD basically. KD is a concentration ligand that occupies half of the available receptor population. So that's another definition of it. So that's an easy way to find it. So if we do an experiment where we keep increasing the amount of ligand or drug molecule, and then we measure how much of the receptor is occupied, we can get a curve. And at the point where we have 50% of the receptor occupied, that's also considered the KD. And that would be right on this slide here. If we look at, and again, it's just arbitrary units on the x-axis, concentration of drug. As we increase it, and let me clarify, this would be a bunch of different experiments, or at least a bunch of different wells, or batches of cells or receptors that we're basically trying to bind the drug to. So I'll give you an example. Like if the kind of thing that I've done in the lab, mostly with transporters, is you have maybe 3 wells of cells with one concentration, and then 3 wells of cells with the next concentration, 3 wells of cells with the next highest concentration or higher concentration, and then you get the average and then get the standard deviation. You plot it as points. So this has to be done, with a lot of experimentation and a lot of wells of cells, or it could be the receptor bound to something else, but usually it's actually in a cell, and you just and then you plot it all though on one graph, all those different points, and you get a curve. And you can't really see the points here, but you can imagine there might be one here, 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 here. You get a curve. And let's just look at these two hypothetical drugs. Drug 1 in red, where the solid line is going up. As we increase the concentration, eventually we can get to 50% of receptors occupied. And if you drop down to the baseline, the x-axis, and figure out that concentration, then that would be considered the KD. Drug 2, it's not perfect here because the only way you're going to, now let me clarify. Basically, you normally want to go to a flat point, and with the red one, we got to the flat point. We showed maximum receptor occupancy, whereas the black one, we didn't really see the flat point. However, I kind of corrected for that or made that easy because we do have 100% occupancy based on the y-axis, so it really doesn't matter. But essentially, we're going up, 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 and 50% would be about right here, and then just whatever that value would be, then that would be the KD. Okay, so something you might notice immediately then is if we're comparing two different drugs, you want to know, well, which one has the higher affinity. Well, it's always the one that is shifted to the left. The furthest to the left is the highest affinity when you're doing a receptor occupancy, drug concentration type of curve. The next term that I want to talk about is efficacy. Pharmacological efficacy describes the magnitude of biological effect for a given percent receptor occupancy. It's important to understand that efficacy has a very different meaning in the clinical world, in pharmacy practice, and I wouldn't say one of them is more correct than the other. You just have to clarify which type of efficacy you're talking about. So, clinical efficacy would be, how well does the drug work for the disease you're treating, and that's just to summarize without getting into too much detail. But pharmacological efficacy is much more, kind of on a molecular level, much more specific. So what biological response do you get for a given percent receptor occupancy? That means, for example, we have a scenario here. At 50% receptor binding, drug A causes heart rate to go from 70 beats per minute to 190 beats per minute. At 50% receptor binding, drug B causes the heart rate to go from 70 beats per minute to 100 beats per minute. This is a real simple one, and it's easy because if you're comparing the exact same receptor percent receptor binding, which we are doing here, that's 50 and 50, and one of those drugs has a stronger response, we automatically conclude there's a higher efficacy. That would be drug A. So they bound to the same number of receptors, but drug A produces a stronger response. So it's that simple. So pharmacological efficacy is only comparing receptor occupancy to biological activity. It's important to understand that can only be measured, if you have the receptors in some kind of a pure form in a cell line, in kind of in vitro in an experiment. So if we're looking at a whole organism, you can't really know pharmacological efficacy because it's going to be a lot harder to measure the receptor occupancy, and you're going to have a lot of other receptors that might be causing confounding effects. So looking at the dose alone or concentration alone, you could not reveal the efficacy because you may not accurately know receptor occupancy in that situation. So on a graph, it would look something like this. Okay, on the x-axis is percent of receptors occupied, so it goes up to 100. The y-axis is the beats per minute. I'll use a lot of cardiac references because I've been teaching that longer than anything in cardio PT. So drug A if it looks like that, okay, and that's pretty common to see. It's flat at the beginning, and then it slopes up very rapidly, and then of course we reach some maximum because everything has a limit, right? Your heart has a limit for total beats per minute, and I try to make it kind of somewhat realistic. And as you know, if any of you have really pushed your hearts to the limit, once you get up around this range, it's really, really tough to really continue at that heart rate. It's actually, most cases, is not recommended. But it's just kind of just saying, like, if you're sprinting as fast as you can on the treadmill, you might get up to that. Unless you're a really conditioned athlete, and it's a lot harder. Drug B. Well, guess what? So, well, both of these drugs produce the same maximum, right? But drug B, it was not as well. We're going to call it potent. I'm going to say potent, but it's really efficacy. So drug B took a higher percent receptor occupancy to reach maximum, whereas drug A was, between 25 and 50%, maybe 40 something percent occupancy to reach 100% activity or maximum biological activity. So again, we'll stick with this rule. If you're comparing multiple curves, the one furthest left is going to be the higher efficacy drug. Okay. There are strange scenarios where one drug might not reach the same maximum, and I don't want to get into that right now because it's complicated. But for instance, a drug might show more potency, or I'm sorry, more efficacy. Okay, and potentially sometimes not reach the same maximum. Again, it's a very specific situation. It's not super common, but it can happen. Oh, and then drug C. And there it is. And of course I just talked about that, and I apologize for forgetting that I had that next. But what does that mean then? So if a drug it's actually reaching the maximum beats per minute, okay, and maximum beats per minute is 140 for that drug, even though the other drugs produce 200 approximately. So why can that even happen? Okay, I want you to think about that for a few seconds and try to understand. So if the drug, now let's look down here. It bound to 100% of the receptors, right, at some point. If the drug is binding to 100% of receptors, but it's still not doing what these ones do, it's not as strong, the effect, that has to mean that the drug affects the receptor in a different way, and it just doesn't activate it as much. Okay, and I want you to keep that in mind, because there are examples like that. Like I said, that if you can completely occupy a receptor and still not get the maximum response achievable by that system, that biological system, and that has to do with the conformation of the receptor, and we're going to talk about that later. So a few more points on efficacy. Again, a drug with high affinity may have low or no efficacy because it's not intended to activate the receptor, but it still binds to it. And many drugs are like that. A good example, and that's, I'm not getting to the third bullet yet, and I'll do that in a minute, but I just want to give you an example of drugs, like a drug that would have high affinity but no efficacy. That would be like a beta blocker to slow down your heart rate, and that's intended to compete with your natural activators or agonists, which will be epinephrine and norepinephrine. If you give a beta blocker like propranolol, it competes with those, and when the propranolol binds, it prevents the receptor from being activated. Okay, so that is, it's going to have high affinity but no real efficacy. On the other hand, we do have some examples, they're not super common, but some examples of drugs that are intended to have efficacy. So the drug itself is going to activate the receptor rather than inhibit it. And one good example, again, is the alpha-1 adrenoreceptor agonists. That would be like if you go to the pharmacy and buy, and this is getting more and more complicated as the years go by, because we used to just say, I want some Sudafed. But now, if you go over the counter, just over the counter and buy Sudafed, it's usually phenylephrine. Now, phenylephrine is an alpha-1 agonist. But it's confusing for some patients and even healthcare professionals because Sudafed used to be only pseudoephedrine, and now pseudoephedrine has to be purchased through the pharmacist, and you have to give your driver's license, so you're not utilizing it to, to produce meth, and so they could track it. So, it's actually a little cloudier. There's a gray area out there as to, for some people. So what do I buy for a decongestant? In fact, both of those are alpha-1 agonists, except the pseudoephedrine, which is behind the counter, that actually works much better because it has better absorption and better bioavailability. Okay, and that's kind of a tangent, but it's something that I found interesting, that they're still naming products with the same brand name, but then they're changing the active ingredient, and it gets a little bit confusing. But that would be for nasal congestion, right? So you'd want to stimulate alpha-1 receptors to constrict those blood vessels, and that would prevent fluid buildup and pressure in the capillaries in the nasal cavity. And I'll go on that a little bit more on the next slide. So if we want to compare efficacy of alpha-1 activators or agonists, we can do that. We have this kind of graph here to do that. So we can look at, as I mentioned, phenylephrine. That's usually what you find. You can find that over the counter, and one brand is Sudafed. There are other brands, generic ones, phenylephrine, and you could look at based on the fraction of receptors occupied, and one would be 100%, by the way, and 0.5 would be 50%. You could look at the response. Okay, in E max, this is E divided by E max, but E max would be 100%. Whatever the response is, we're talking about vasoconstriction here, blood vessel constriction. So it's telling us that we can get basically divide the response for this receptor system divided by the maximum response, right? And so this is just a fraction of the maximum response is what we're seeing. And the whole point here is that phenylephrine gives you response at a much lower concentration than oxymetazoline. Oxymetazoline is usually used for things like eye drops, maybe in other things, but you can find it in eye drops. You could find, or nasal sprays, I should say. And those are usually, a lot of these are found in both, but another one would be nefazoline. But at least those three on the left are both pretty strong alpha-1 activators or agonists. Now nefazoline is not super strong, but it still has a good duration of action. But the whole point here, just to get back onto the point, the whole point is that all these drugs have a different efficacy, a pharmacological efficacy, in terms of their ability to activate alpha-1 receptors. Okay, and every one of these data sets would have to be gathered from a different tissue set if you're doing a real experiment. And this would represent a really high number of different experiments, or a high number of tissues. So normally you would, for each data point, you might have three tissues or three samples of tissue that you would test. And that, again, that would be for each data point, and then you do that for each drug. So this would be a really large experiment to do, unless you're really used to that. But essentially, just showing you that they're all going to be different. Now, in the real world, let's think about this. How much does this matter? Well, if I know I can still get a good response with oxymetazoline, even if it has a lower efficacy, that's probably fine, right? You would just give a higher amount. Most likely just give a higher dose, right? Something like that. So it's efficacy. You have to have some efficacy for something that's going to be, you want it to be an activator. It has to have efficacy. But you should never automatically assume a drug with higher efficacy from a pharmacological perspective that drug is always better, because it may not be. It's just important to understand. Now I want to go into just a little bit of history on how scientists kind of initially believed ligands interacted with receptors, and this is something called the occupancy theory. So just again a little summary of what happened. Langley and Ehrlich quite a while ago developed the concept of a receptor. A scientist named A.J. Clark was the first person to describe quantitatively the interaction between a drug and a receptor. And he said the magnitude of a biological response is directly proportional to the number of receptors occupied by the drug, and a maximum response could only be obtained when all receptors were occupied. Okay, so in his opinion or belief, drug action depended on two factors: binding of the drug to the receptor, or fixation, and ability of the drug to produce its action after fixation. So we already talked about these two things. That would, what we talked about was affinity and then efficacy. So that's pretty much the same idea, and that's pretty accurate. But I want to dig into this a little deeper. This whole statement that the magnitude is proportional to the number of receptors occupied, and you need to occupy 100% of receptors to reach 100% activity. So this is graphically, this is what it would look like. It would be linear. For the most part, it would be linear. But he was saying that you need to get to 100% occupancy to get to 100% biological response. Okay. Now, later on, some other scientists, such as Stephenson, Furchgott, and Nickerson, had some other ideas. And Stephenson proposed that a maximum effect could be produced by a substance occupying only a small proportion of receptors. The response to a drug was some unknown positive function of receptor occupancy. And what he meant by that, by saying unknown, is that every drug, in his opinion, right, through his hypothesis, every drug has a different ability to produce a response when it binds to the receptor, and you can't know that until you test it, until you do some experimentation. So drug X, for example, just a kind of hypothetical drug, he was saying that maybe it would take a certain receptor occupancy to produce the maximum biological response, whereas another drug might take less or more receptor occupancy to produce the maximum biological response. So this was really in direct opposition to A.J. Clark, because he was saying that you do not need to occupy 100% of receptors to get the full biological response in some cases. Okay, and if you knew nothing else about this, which most of you probably haven't really looked into this beyond what we're talking about now, it would make probably more sense to most of you the occupancy theory, which would be we need to occupy 100% of receptors to get 100% of the biological response. Right? That makes sense, right? If you activate every receptor, you get the highest response. However, again, these guys are saying that's wrong, and they actually produced some proof supporting that they were correct. Okay, so they provided direct scientific evidence for Stephenson's propositions. They proved that the assumptions made by Clark and Arians were wrong, that the response is linearly proportional to the number of receptors occupied. So this is what Stephenson, Furchgott, and Nickerson proposed, that we may reach close to 100% 100% biological response with less than 100% receptor occupancy. That means it's going up. We've already given the highest biological response with less than, maybe, like, we'll say 75% of receptors occupied. And this is just a hypothetical example. The curve could be shifted even further left, potentially even 25% receptor occupancy or less. So that was a kind of a controversial idea at the time. Okay, and it's proven to be true, right? It's proven to be true now that we do not need to occupy 100% of receptors to achieve the maximum biological response. And I'd like to think about that for a little bit. Maybe pause the video so I'll continue, but pause the video for a minute or 5 minutes and think, why would a system be able to, or how would it be able to produce a full biological response even if I'm only activating maybe 10% of receptors or 20% or something like that. I want you to think about that. Okay, so if you hopefully spent some time thinking about that, that idea, and I'll just give you a little bit of kind of a hint here. It's related to the fact that what's happening inside the cell is sometimes saturated or at its maximum capacity. So for instance, if you activate, I'm just going to give you a hypothetical example, if you activate 10% of receptors, what if that you've already saturated or reached the maximum capacity for those signaling molecules inside the cell to do what they're doing, or even the final endpoint, which is if you're causing vasoconstriction of a blood vessel, if you had calcium influx, what if you've already achieved the maximum calcium concentration prior to occupying all the receptors, right? So the whole point is that you're depending on a lot of components of a very complicated pathway, and those components could be the limiting factor, whereas the receptor may not be the limiting factor in the response. Now I want you to get prepared, because we're going to switch to the modern theory, which is not really in opposition to those other theories, but it's not really in opposition to Furchgott and Nickerson in that last theory that we talked about, but it digs into it a lot deeper, and now it's not really a new theory anymore, but it's something that when I was a student I didn't really learn, something I had to look into when I became a professor. So this is called the two-state theory, and the theory is that receptors spontaneously switch between two conformations, an active conformation and an inactive conformation. So we look on the bottom here, it's also on the cover of your handout, okay? If you look on the bottom here, we have R and then R star on the right. So just R on the left and R star on the right. The R stands for inactive receptor. The R star asterisk stands for active receptor. And I want you to, for a minute, forget about this agonist, which would be basically an activator or a drug molecule. Forget about that for a minute and just imagine a situation where this receptor can bounce back and forth. And there are literally different conformations or different shapes, bounce back and forth spontaneously in the absence of any ligand or drug. And they've proven that can happen in many cases now. Some receptors like histamine receptors, some alpha-1 receptors, and other ones, they've shown that even without an activator, the receptor some of it could be in the active state. Okay, and that really threw kind of like a monkey wrench or a curveball into the whole field, because then they had to, if that were true, then they had to figure out, well, what are the drugs actually doing in this process, right? How are they modifying it? And what they found is that rather than, and this is going to take a little thought and a little time to digest, I think, but rather than saying that the drug activates the receptor, they were saying that when the receptor is activated spontaneously, that the drug will bind to it and it'll stabilize it in that active conformation. So as you know, every drug has to have a complementary shape in the receptor binding pocket in order to have affinity. So what they're proposing is that once the receptor is active, it has a particular conformation that has higher affinity for the agonist. So the agonist will bind and lock it into that active conformation. So I want you to remember that these agonists, in most cases, it's temporary or reversible. So that might go on and then come off and then go on and then come off. And remember, so because this is an equilibrium, when the agonist comes off, this receptor is free to go back to the inactive state and then back to the active state. So it goes back to its equilibrium. And that's the theory, and there's some good evidence to support that. So, and this is a little more on that, just a really kind of like simple animation. If any of the different types of ligands dissociate from the receptor, or separate from it, the receptor may regain its equilibrium, alternating from inactive to active until the ligand stabilizes its preferred conformation. So I want you to understand that the whole idea is that the receptor will have an equilibrium, which will be active and inactive conformations. So remember, we might have millions or who knows how many copies of the receptor on the cell, but some of them will be active and some of them will be inactive. And the whole idea is that once it is active, an agonist will lock in or kind of like bind to it, and in most cases it's temporary and then it'll come off, but it will keep it in this active conformation for a longer period of time than normal. So let's see how that looks. The agonist comes off. Okay, just imagine that red spiky thing is the activator or agonist. Once it comes off, the equilibrium should occur. So if it's just one receptor molecule, it's going to fluctuate. If we're lucky enough, it depends on our goal, but if that's lucky or not, but if we are fortunate enough that the agonist is close to the receptor when the receptor is in the correct conformation, then it will bind to it because it has affinity for that conformation. And I showed that as a kind of a matching shape there. When it matches that shape, it will lock it in that conformation. Okay, and that's temporary. But even though it's temporary, it's longer than it normally would be. So the point is that we're going to push it. If you look at 100 receptors or 1,000 receptors, we're going to push more of them towards the active conformation because we're going to stabilize them in that conformation. So this also means that this two-state receptor theory would allow a receptor, it will allow it to be active even if there are no ligands in the body or in the tissue. So if I took a cell, and this is actually getting a lot easier to do, and I've done it before with transporters, but if you do it with a receptor, if you add the gene, human gene for a particular receptor to a cell, and that the cell expresses the receptor on its surface, it should, in theory, many of those receptors will exist in both active and inactive conformations. So that means there's some baseline level of activity, and you can increase it or decrease it depending on what type of drug you use, but you basically have a baseline activity even without a ligand. So if you think about that with respect to like the human body, that would mean that if we didn't have endogenous activators like epinephrine or norepinephrine or anything you could think of that activates a receptor like histamine, if we didn't have any of those present, what they're saying is that you would still have some receptor activity, but it would be lower because more of the receptor would be in the inactive conformation in that case. And don't worry too much, we're going to build on this, or at least try to give more examples of this. Okay, so why don't we actually define this, like formally define this like agonist term. So an agonist is a substance which binds to a receptor and produces a biological response. Okay, historically receptors were thought to have no activity in the absence of an agonist, and that older view is shown here. So this is considered less accurate now. So the older view is that when you add an agonist to a tissue with a receptor, they start off separated and then they bind and then produce a biological response. Okay, now the only thing missing here, what's missing is that the idea that the receptor can undergo or become activated without the agonist there. Okay, so the agonist is so this is basically somewhat wrong. Okay, the agonist doesn't always have to be there to have an active receptor. Okay, so we'll move on, and there's going to be several examples of this two-state theory to hopefully make sense out of it. There are other terms now. So we just talked about an agonist. So an agonist is something that is able to produce a biological response. Okay, and I kept it at a very basic, vague definition, and I'll tell you why now, because there are so many types of agonists. Just to say just a plain agonist, we're to keep that kind of a general definition, but then we're going to get into all the different types and give further details. So a full agonist is a substance capable of generating the maximum biological response a system can achieve at 100% receptor occupancy or less, right? So the whole point here is that a full agonist, at some point, if you give enough of it, it will be able to produce the maximum response that that biological system can achieve, whatever that response may be, right? It could be inflammation, vasoconstriction, heart rate, cell division. It doesn't really, it could be anything, right? There's so many receptor types. But it produces the maximum effect achievable by that system, even if, well, at 100% or less receptor occupancy. A partial agonist, and there's the definition there, but I'll just kind of in my own words summarize it. A partial agonist is an activator or agonist that never produces the full biological response that the system can achieve. So I mean, if you gave grams and grams or kilograms of a partial agonist, it would still never produce the maximum biological response, even if it occupied 100% of the receptors in the system. And that is because of the way it interacts with the receptor. And I'm going to show some examples of that with respect to the two-state theory in that context, what a partial agonist may look like. Okay, so regarding affinity and efficacy, full agonists have affinity and efficacy. Partial agonists have affinity and some efficacy, but not the maximum efficacy in many cases. Okay, varying degrees of efficacy, but generally lower efficacy in many cases. Okay, than a full agonist. Partial agonists may appear to be inhibitors or antagonists in the presence of a full agonist. And this is where it gets a little complicated, and I wish I could make it simpler, but it's a little difficult to simplify it anymore. This is basically, probably for the whole module, this is one of the more difficult points that seems to give a little bit of trouble every year. A partial agonist, if you mix that with a full agonist, I'm saying, like, just imagine you have a cell with a bunch of maybe 100 receptors or something like that. If you mix that partial agonist with a full agonist, they will compete with each other. And the partial agonist, because it has a weaker effect, it will make the average biological effect less than the full agonist would be on its own, right? So they're kind of balancing each other. So the scenario would be if you started off with just the full agonist by itself, and then you decided to add a partial agonist later, that would decrease the total biological activity, because it would push the receptor population to a little bit less active. And I'm going to show you that in the context, in a little while, in the context of a two-state theory. Before I do that, I have one graph here. Again, this is the same graph that we talked about with the alpha 1 agonists. And now, so you've already seen this, but now we're just going to talk about, so how do you identify a full and a partial agonist? Well, it's pretty simple. So this 1.0 is 100% of the maximum biological activity. So we know that phenylephrine, eventually, we reach 100% of the maximum biological activity that system can possibly create. So that means phenylephrine is a full agonist. So by definition, anything that's weaker than that, or anything technically that produces a lower maximum activity, it has to be a partial agonist by definition. Okay? And so why are we talking about partial agonists, I guess, is one question that might be raised. And that's because now there are a few drugs out there that utilize this, and one of them is for smoking cessation. I think it's Chantix, I'm pretty sure, but that is a partial agonist that has some stimulation of the nicotine receptors, but not full stimulation. So it still gives you some activity, but it doesn't give you that really strong activity from nicotine. So it may, in some cases, it may be beneficial to give a mild stimulation of a receptor system. In this case, if you look at oxymetazoline, notice that it starts to get flat before it reaches 100% of biological activity that the system can achieve. So that means oxymetazoline, by definition, should be a partial agonist. Okay, and I know I was talking about nicotine, but all these on this slide are unrelated to that. These are just, really for nasal congestion, or clonidine and tolazoline have different purposes that we'll talk about at some other point. But this slide is showing really alpha-1 activity, alpha-1 receptor activity, which would be really vasoconstriction. So hopefully I can demystify this a little better now with this slide here. We're going to start to show, so with each different type of agonist, what does it do to the receptor population. So I think this, I really think this helps, so I hope it does. But what happens is, imagine if we start off with 1, 2, 3, 4, 5, 6 receptors. Of course, it's never going to be just 6. But whatever receptor it is, if we had 6 of them, notice that the ones that are free or not occupied by a ligand, I'm showing that it's 50%, 50%. So if we go back to that slide that showed 50-50 the first time, what I'm getting at here is that only the receptors that are free or unoccupied are the ones that are they're going to reach their normal equilibrium. It doesn't have to be 50-50, right? Sometimes it might be 80% active, 20% inactive. Every receptor is different, right? But whatever their normal equilibrium is, the free receptors will reach that, but the occupied receptors will not. And that's the really important point here. These occupied receptors, right, will be, they'll be active or inactive depending on what is bound to them. So remember, if this one receptor, for example, were fluctuating between inactive to active, inactive to active, if we had an agonist or full agonist that bound to it in this conformation, right, because it has a matching, we're just saying a matching shape, but it has also matching or complementary chemical bonds that'll bind to it, and it will lock it there for some period of time longer than normal. And if we have multiple copies of that, then on average, right, at any point in time, we'll have more receptors in this active state than normal. And that's, it's not going to be every receptor, right? It's going to be some receptors will have drug and some won't. And it's not really a drug. If we're talking about an agonist, it's usually, and it could be, like I said, it could be, but it's usually going to be, in most cases, an agonist is usually something like an endogenous activator like epinephrine or norepinephrine. But if you wanted to use the ones that we just talked about, the decongestants, you could use that as well, because those are drugs. But imagine that were if that were like phenylephrine binding, it would shift the equilibrium to the right, because these ones are trapped in the active state. Okay, and that's only one drug, okay, or one ligand, and it gets a little more complicated. So I'm going to continue talking about the types of agonists before we get into some of those more complicated examples. So an allosteric agonist, by definition, it's altering the response or the affinity for a normal agonist. And what I mean by that is, if you have an allosteric agonist, that means by definition, you still have to have a normal agonist, but then the allosteric one binds at a different site. Okay, so they're chemical compounds that increase, could be either or, increase the affinity or efficacy of an agonist, a standard agonist, and that could be a full agonist, for example, for receptors by binding to and altering a receptor's conformation. Okay, and again, they bind at a site distinct or separate from the agonist binding region. So I have just a really quick animation here to show you if we had agonist alone at a given receptor, it might look like this. It kind of fits, but it's not perfect. If I give an allosteric agonist, it's going to bind to a different site on the receptor here. Okay, and that will change the conformation of the receptor by definition because it's an allosteric agonist. that conformational change, if that gives a better fit or complementary shape to the agonist, that will give a higher affinity. Okay, so that's just that example here, just a higher affinity. Now we can get, and I don't think I have it here, but coming up, but you can imagine hopefully that even if I didn't affect affinity, the allosteric agonist might change efficacy if it increases, can increase the activity of that receptor upon ligand binding or agonist binding. So it could either affect efficacy or affinity or efficacy, okay, depending on which type of allosteric agonist we have. On a graph, it would look something like this. I want you to look at the curve on the right first, or the blue one is your starting point or control curve. And what we're doing on the bottom here is we're just giving more and more of your normal. We'll just call it a full agonist for now, to make it easier, just at least to pick something. We'll say full agonist. We're giving more and more, and then it goes up, 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 and we get the maximum biological response. However, if I did that in the presence of a little allosteric agonist, the curve would shift to the left. A little more allosteric agonist, it would shift to the left even more. And what we're seeing is, it's really hard to tell because we're not looking at receptor occupancy. We're looking at the biological response. So it's hard to tell, did we boost affinity or did we boost efficacy by itself, or biological activity by itself. It doesn't, we don't need to know that at this point. I want you to understand though that you'll see the curve shift to the left, which means that the allosteric agonist allowed us to get a stronger biological response at a lower concentration of your full agonist. So if you look here, we're a lower concentration than we are at the same biological response on the first curve, right? Again, that's a little bit higher. So that just means that we've made the drug work better by giving an allosteric agonist. The next type of agonist is considered an inverse agonist. Inverse agonists were something that wasn't even known. They weren't known to exist for a long, long time in receptor theory. And maybe the past, 20 years or so, they started to realize that this could happen. And this is only something that really came out into literature because they realized that the two-state theory of receptor activity, or two-state receptor theory, was accurate. So remember that a receptor can be active or inactive and fluctuate from those two different conformations, fluctuate again from inactive to active, active to inactive. And because of that, there is an opportunity if you can lock that receptor, or some copies of that receptor, lock them in the inactive state for some period of time, the average total biological activity of that system could be reduced. So that requires that, first of all, again, for an inverse agonist to exist, first it requires that there is some active receptor at baseline. And I mean without any ligands available. So imagine with this dotted line here at the beginning, imagine the receptor is sitting there, we'll just say like 1,000 copies, or who knows, but several copies on the cell membrane. And imagine, at this point we still have no ligand, but the receptor has some activity because some of them are in the active conformation. Then imagine we give a drug and it actually goes down. Whatever this biological activity is here is going to go down. And that would be considered an inverse agonist effect. And the only reason why they believe that can occur is because some of the inverse agonists, actually all the inverse agonists, if it binds, right, any of it that binds will bind to the inactive conformation and it'll shift it downward. Okay, and I'll show you an example of that just in a few minutes. And again, it's critical to understand that inverse agonists only exist in systems that are constitutively active, or systems that have at least some percent of the receptors being active, in their even in the absence of a ligand, right? There's got to be some active receptor in that equilibrium. So what it would look like is that, again, we're going back to that first example. Just imagine the normal receptor equilibrium was 50-50. So anything that's unoccupied would be 50-50. Okay, and that's just a hypothetical example of the ratio of inactive to active. But we have to have some of it. Some of it has to, in the normal equilibrium, some of it has to have activity in order for an inverse agonist to show any effect or to even exist. So the inverse agonist, though, by definition, only has affinity for this inactive conformation, right? It only has affinity for the inactive conformation. And that means, well, the inactive conformation must have some binding pocket that's different, right? Something about it must be different from the active conformation that'll give it affinity for the inverse agonist. So I'm just to make it simple here, I'm just showing, well, maybe there's a binding pocket over here, for example, that it binds and it shifts it to the left. Okay, so that would give you the majority of the receptors in the inactive conformation, right? And that would decrease your baseline activity. So now that we talked about agonists, I would like to talk about antagonists. Now, I need you to be aware that for many decades, antagonists were just considered just inhibitors, right? They just block the receptor activity. Now we have a much better understanding of what they do, and what we used to think were just antagonists, because literally we just call anything that inhibited the receptor, we just call it an antagonist. Now we're finding there are different degrees of antagonism. The ultimate antagonist would really, or I would say the ultimate inhibitor would really be the inverse agonist, right? Because that forces the receptors to be inactive for the most part. However, they were forced to kind of reimagine or kind of redefine these terms, because you can't just say a drug is a simple antagonist anymore, because there's so many different types. Okay, so what I mean by that is antagonists no longer just mean, at least from a pharmacology perspective. Now, I'll be honest, like if you're out there in the practicing world, practicing pharmacy, I think the majority of pharmacists would still just call any inhibitor an antagonist. But from a pharmacology perspective, an antagonist has a much more specific definition. And again, so we'll get into this first, and then we'll get into that more detailed definition. But the practical definition is a substance that reduces the biological activity produced by a receptor. Okay. Although an antagonist is often assumed to work by directly binding to a receptor, some types of antagonists do not interact with the receptor whatsoever. Okay, so I want to clarify that. Most of our discussion has been about receptors, right? But there are inhibitors or antagonists that don't even touch the receptor. Okay, we're going to get into that in a little bit and give some examples of that. Now, like I said, pharmacologists have complicated things substantially. Okay, now antagonists of receptors are defined based on the two-state theory. Okay, their activity is context dependent. Okay, and I'll show you what I mean by that in a little bit. Okay, so if this two-state theory is accurate, which they believe it is, they had to figure out where these antagonists will fit into that. Okay, we're going to talk about that in just a few minutes. Antagonists that do not bind to receptors are just simply inhibiting the biological activity generated by the receptors. Okay, and I'll show you what I mean by that. When I go over every different type, I'll go over every different type of antagonist. So there are chemical antagonists, physiologic, indirect, competitive, which can be broken down into reversible and irreversible, and then allosteric. Okay. So this first one is pretty simple. Chemical antagonism involves a direct chemical interaction between the agonist and the antagonist in such a way that renders the agonist pharmacologically inactive. So the chemical antagonism is nice and easy because it has nothing to do with the receptor. Not really, right? So it's saying that it's like a chelator, right? A chelating agent is a chemical that will bind to a metal to inhibit its activity. So if I had, and there are a few, believe it or not, there are a few examples out there now of different types of drugs. There are inhibitors of, for instance, the vascular endothelial growth factor. That's a ligand for the VEGF receptor. There are inhibitors for the actual ligand rather than the receptor. So it means that some drug is binding to the actual ligand and blocking it before it even touches the receptor. So that's chemical antagonism. Physiologic antagonism is very different from what we were talking about with all those receptors. It's basically saying that by whatever means it does it, the physiologic antagonist produces the opposite biological response of the agonist. So it could do that through many different mechanisms. Okay, so a good example is the effects of acetylcholine versus the effects of epinephrine on the heart rate. Acetylcholine slows down the heart rate, epinephrine speeds up the heart rate, but they have totally different receptor systems, right? Acetylcholine is affecting muscarinic receptors, epinephrine is affecting beta-1 receptors or adrenergic receptors, but they produce opposite biological responses, right, through totally different receptor systems. So that means that on the physiological level, they oppose each other, but not really on the receptor level. They're not working on the same receptor is what I mean. Indirect antagonism means you will block the effects of a receptor, not by binding to the receptor, but by inhibiting something that happens after the receptor is activated. Okay, so imagine agonist with receptor A, agonist with receptor B. I'm showing you that two different receptors might produce the same biological response, and I'm showing in this case generation of inositol triphosphate, which would normally increase calcium channel activity. Okay, so this Y here is supposed to represent this indirect antagonist. So if we block, for instance, calcium channels, that in those calcium channels, right, those were in the pathway much later than the receptor, that's called indirect. So we ultimately blocked the final outcome, which was contraction, but we didn't do it by blocking the receptor, we did it by blocking something that happened later on. So that's indirect antagonism. So on an actual graph, an indirect antagonist might look something like this. Now, to be honest, these can potentially change depending on what you're inhibiting, but in many cases the curve would look like this. So just imagine the solid curve or solid line would be the control curve. If we have whatever the tissue is, we're to increase the amount of agonist in that tissue. Okay, and I just want to make note of this. So the x-axis is the dose of the activator or the agonist. Okay, and we're just talking about a standard, like a full agonist, for example. Okay, so if we're increasing the activator, of course the biological response will go up. Okay, and if we look at the left here, imagine that's just agonist and nothing else. We're just increasing agonist. But the curve on the right would be, if we're doing the same thing, we're increasing agonist, but we also have the presence of an indirect antagonist. So we're activating the receptor, but we're inhibiting something later on in the signaling pathway. In a lot of cases, it's going to lower the maximum biological response. So we're shutting off, to some extent, shutting off the inside of that pathway or the intracellular pathway, and that can block the maximum biological response. And also, please make note, it also shifts the curve to the right. Okay, and I'm saying if you pick any point on the control curve, if you look at the control curve and the antagonist curve, any point where they're going up, it should be shifted. The inhibition should shift it to the right, and that gives you a weaker response to the agonist. Right? So anytime you have any antagonist at all, compared to an agonist, right, that antagonist should make that curve shift to the right. Okay. So if I gave more, of course, more indirect antagonists, it might shift the biological response lower and then even lower. Okay, so we can actually, in some cases, reduce the response that's achievable by that system. Even if we keep giving more activator or agonist, that indirect antagonist may have limited our response achievable by the system. Okay, and that's actually the goal in many cases. We do have calcium channel blockers that block activation of calcium channels, or at least block the flow of the calcium that would normally be activated by some kind of adrenergic agonist. So we've talked about chemical, indirect, and physiologic antagonists, and now we're going to talk about competitive antagonists, which are actually the more common type in practice out there. In this case, agonist and antagonist compete for the receptor binding site, and so binding of an antagonist prevents binding of the agonist until the antagonist dissociates or falls off from the receptor. In that third bullet, again, that's only in the case where it's reversible. In some cases, it is irreversible, right? And we're going to talk about how that looks. Okay. We now know that competitive antagonists do not simply block receptor activity, but instead they maintain the physiological ratio of inactive to active receptor. So that's a potentially very confusing statement, and I'm going to show what I mean by that. Now, remember, I said antagonist, and it's still out there in practice. A lot of healthcare professionals might just call an antagonist, any inhibitor as an antagonist. But the pharmacological definition now is that an antagonist really just it tries to or tends to prevent the normal equilibrium of the receptor from inactive and active. It tries to prevent that from changing. It tries to prevent shifting of that equilibrium. Okay, so it's actually an antagonist is actually somewhere in between an inverse agonist and a full agonist in terms of its biological response. So we're at the point now where we can't really consider an antagonist just an inhibitor, and that's because it depends on the context that we're in. So like a pure antagonist is also considered a competitive neutral antagonist, and by neutral that means, neutral means that it doesn't have a preference for the inactive conformation or the active conformation. It actually doesn't prefer either. It has affinity for both. And by definition, it doesn't really alter the normal equilibrium. So if the normal equilibrium is 50% inactive, 50% active, the neutral antagonist will retain that. So you might be asking, then what does it do? If it doesn't do anything to the receptor ratios, what does it actually do? Well, the important point is that for every molecule of antagonist that is bound, nothing else can bind there. So it forces it to stay in this ratio. So it's what it's going to do is resist change. So if I had a full agonist mixed with this, if many of these sites are occupied, they're going to prevent the full agonist from binding. It's going to prevent us from shifting to the right. It's going to keep us closer to neutral or a balanced population of inactive to active receptors. So the activity of an antagonist depends on the context. So in most cases, the body has some natural agonist at the receptor, right? So in most cases, an antagonist will inhibit the biological activity or reduce it, in a living whole organism. However, if I gave someone an inverse agonist, and then I said, well, I'm going to add on top of that, I'm going to add then a standard neutral antagonist, that would shift us back to the middle. So the inverse agonist would shift us to the left. The neutral antagonist would shift us kind of somewhere in the middle, so we have a balanced population. So we can actually show we can actually show an a neutral antagonist potentially showing us some increase in biological activity in the presence of an inverse agonist. Okay. So I'm not going to read through it up the top, all the text there, but I want you to look at that yourselves and think about what that means. Okay, and hopefully that'll help you out a little bit. So I'm going to go ahead. If you want to pause it and read through that and try to make sense of it on your own time, I think that would help you to kind of digest it and take as much time as you need, and then kind of restart or play the video again. So move on right now. Moving on to the next slide. So I just talked about competitive antagonism, competitive neutral antagonism. But what about is it reversible or irreversible? And most drugs are going to be reversible. Again, not all of them, but that means that most drugs bind temporarily. So if this is temporarily bound, and all these are, that means if I give a bunch of other ligands, so if I give a bunch of full agonists, overload this system, well, eventually we'll crowd this out, and when these come off, we'll quickly fill that in with a full agonist. If we're in this conformation on the right, we'll fill them with a full agonist, and that'll prevent shifting to the left. And if any one of these on the left fall off, remember this receptor will go back to its normal equilibrium. It'll shift from active to inactive, active to inactive. And if we have enough full agonist around, we'll trap some of that on the right side. We'll shift the equilibrium to the right. So the main point here is that if we have a mixture of different agonists and antagonists, what we're going to find is a balance between those, especially if they're reversible. That means if they can bind and then come off, and then bind and then come off. The ones that have a higher concentration and a higher affinity will dominate, right? They'll dominate whatever the response is going to be. So if it's a full agonist, that will show more biological activity, right? So it's going to be a balance between all the different types of ligands that we have available. Okay, so it does get a little bit complicated. So hopefully this example really illustrates the point that I'm trying to make here. So imagine we're starting off in a scenario where there is no agonist present, but we have just a little bit of reversible competitive antagonist, and this is going to be your standard neutral one. So that means it doesn't prefer inactive or active, or it basically doesn't change that equilibrium. So some will be bound here, some will be bound there on the right. But imagine this, if this is reversible, like I said, if any of it falls off on the left side, and we have a bunch of full agonists here, we're going to trap some of those that shifted to the right, right? If this falls off, the receptor equilibrium will be retained. But if any of these receptors decide it's their time to shift back to the active conformation, we have so much full agonist that one of these will trap it. You'll trap one of those receptors in that active conformation for a longer period of time than normal, and then it'll keep us mostly, overall it'll keep us mostly active. And the whole point is that, right, whatever is dominant, whatever we have more of in it, has to have high affinity, but basically if it's a combination of affinity and concentration working together to decide, are we shifted to the right or are we shifted to the left? It will be shifted to the right, if we have a lot of full agonist and the antagonist is reversible. Okay, so if I started off in a receptor system with just an antagonist and then I added a full agonist, of course I would activate some receptors or push them in the active conformation and have a biological response. Of course, if I started off with just full agonist and then I gave an antagonist, I would shift it back a little bit back to the left, so it'd have some inhibition of the total biological response, right? Because less of the total receptors would be active at that point. So hopefully that makes a little more sense now. So in terms of a graph, it would look like this. Let's go back to, starting with our simple control curve. Imagine we don't have any antagonists yet, but we keep giving more and more agonists to some receptor system. The biological response goes up, and then it plateaus, right, at the maximum biological response. Now imagine if we gave, we're still giving the agonist, right, in different doses, different amounts, but in the presence also of an antagonist, just a single concentration though, a single concentration of antagonist and increasing amounts of agonist, it would shift the entire curve to the right. Okay, so it shifted it to the right, so that gives us a lower apparent efficacy, but notice the maximum biological activity is the same. And I want you to think about why, and just if you pause it right now, okay, and then I'll continue talking to explain that, but pause it to think about why are we achieving the same maximum biological response in the presence of a reversible antagonist. Okay, so I'm going to answer that now. If you didn't pause it, you have another chance, but I'm going to answer it right now, and that's because basically when you have a reversible antagonist, if you give enough agonist, which in this curve or in this graph, you're allowed to kind of pretty much give as much as you want. You keep going to the right, to the right, to the right. Eventually, there will be so much agonist that the antagonist will have nowhere to bind. Okay, and that's because, remember, even though the receptor, any free receptor is still in equilibrium, most of the receptor will no longer be free. Right, most of the receptor will be occupied by the full agonist, so the amount of available receptor to bind to the antagonist is very low, right? So we won't be shifting it much. What I'm saying is when we give the highest concentration, right, that we can give, we'll still achieve the maximum biological response. It'll just take a little more. So in this example, instead of 100 micrograms, and that's just a mass rather than a concentration, instead of 100 micrograms, it might take over 1,000 micrograms, between 1,000 and 10,000 micrograms. So we still achieved the same response, but it took a lot more agonist. So all that's doing, if you look at this, you can see all that the antagonist is doing is it's tempering or putting like a governor on the response to the agonist. Right? It's weakening that response. But we'll still get to the top. If we give enough, we'll get to the top only because that is reversible, and the antagonist will fall off and will be taken over by that agonist at some point. And all this is showing is that if I continued and did further experiments and I gave even more antagonists, right? We'll say 10 micrograms per milliliter, 50 micrograms per milliliter, keeping more and more antagonists in different experiments, the curve will continue to shift to the right. We'll still continue to get the same maximum biological response, but it'll still take more agonists to do that. So that's what these would do. That's what an antagonist is going to do. It's going to weaken at a given concentration of agonist. We will weaken the response, right? But we can still overcome that if we need to. So I know I talked a lot about combining different agonists and antagonists, but I do have a few more examples to really clarify that as much as possible. So again, this is just revisiting the two-state theory. We know agonists, inverse agonists, and antagonists. Just as a review, remember agonists give us a higher activity in the receptor system. Inverse agonists give us the lowest, and antagonists are somewhere in the middle. Okay, and then there was the one thing we don't have here is the partial agonists would be really between an antagonist and an agonist, or in a full agonist. That would be a partial agonist. So again, inverse agonists strictly bind to and stabilize the inactive receptor. Full agonists strictly bind to and stabilize the active receptor. Antagonists stabilize both conformations of the receptor. So their main purpose is to resist a change in biological activity from an agonist or inhibition by an inverse agonist. So an antagonist kind of keeps us closer to our normal equilibrium of inactive to active receptor. So on the two-state theory, it would look like this. Inverse agonist binds only to inactive, agonist binds only to active. Antagonist doesn't have a preference. Its only purpose is to prevent these other guys from doing anything. Okay. So one other type of antagonism is, and this we already kind of alluded to this because I talked about the covalent bonds. That would be the irreversible competitive antagonism. So the important point here, and the big difference, is that if it's irreversible, once it binds, right, it cannot come off. So you cannot overcome an irreversible antagonist by adding more agonist. What I mean by that is you can get some activity, but you can never completely overcome that. And I'll show you how that looks on a graph. Okay, so, and that's coming up in just a little bit. But first, before I get to that, I'm going to show you kind of like what it would look like, first of all, without the agonist, and then with the agonist. So without the agonist, well, this doesn't look any different yet, right? It doesn't look any different from the reversible competitive antagonist. So this irreversible would bind, but those are permanent, okay? But everything else is going to look the same. We still have 50% inactive, 50% active. Again, this hypothetical ratio that I have here for this, kind of hypothetical receptor. In this case, if I added a high dose of full agonist, well, by definition, right, these are permanent. This is permanent. These are stuck. But whatever was available, whatever was still there, I can bind to that. Remember, the full agonist, though, only binds to the active conformation. So as these will fluctuate back to active, back to inactive, back to active. But if they get to active, and the full agonist is in the vicinity, that will bind and lock it in place. Another one binds, locks it, binds and locks it. So if we lock enough of those in place, at least for some period of time, right, we will shift the total number of active receptors, well, basically more active receptors will shift this to the right. Okay, but that's only the ones that are not yet bound by antagonists, because this is locked in this case because it is irreversible, right, which is different. And how does that look then on a graph? Irreversible competitive antagonism would look similar or pretty much the same as the indirect antagonism that we talked about earlier. And remember, because some of those receptors are permanently occupied, they cannot be activated again. The ones that are kind of occupied in their inactive state, they cannot be activated again. So in some cases, with an irreversible competitive antagonist, we will see that the maximum biological response attainable by a full agonist will go down, right? So that antagonist will shift the maximum down. Remember, with the reversible antagonist, we were still able to achieve the maximum biological response. If we just had, we just had to give more agonist than normal. But with the irreversible, we, in many cases, cannot achieve the same maximum biological response, right? That'll be diminished to some extent. So if I did that, in more experiments, if I added even more antagonist, the maximum response should go down even lower. And remember, in every case, the curve should never shift to the left if we're talking about an antagonist. They should shift to the right and sometimes down, right? If we're talking about irreversible, it'd be down, but also to the right. In every case, every antagonist, at some point the curve should be shifted to the right, right? If we're looking at kind of like parallel portions of the curve. That means we're decreasing the response to the agonist. Unfortunately, like most things in the world and in science, there are exceptions. Okay, the exception is it's all related to this. Remember the occupancy theory that was proven wrong, that said that not 100% of receptors need to be occupied to achieve a maximum biological response. Okay, that's that. Remember that theory that some receptors don't have to be occupied to get a full biological response. So I want you to think about, so how does that relate to this? The exception that I'm talking about is that in some cases, even an irreversible antagonist, some cases will still allow you to achieve the maximum biological response if the irreversible antagonist only occupies a small percent of receptors, or a percent that's small enough that you still have enough available receptors to achieve a full biological response or to be occupied. Okay? And that's called the spare receptor theory. So here's how it would look. Remember, we just said that this is what you would normally see with an irreversible antagonist. However, they found that if you give a low enough amount, you'll still shift the curve to the right with a low enough amount of irreversible competitive antagonist. But you'll shift the curve to the right, but at a low enough dose, you'll still achieve the same maximum biological response. And that means that there were some, you only inhibited a few receptors, and that there were enough available receptors that, imagine if you only have to activate 5% to achieve the maximum biological response. And if you activate 5%, even if 80% are inhibited, you could still get to here in some cases. So that was the exception to that rule of a decreasing maximum biological response. Okay, so this is a real-world example of adding a competitive antagonist to an agonist. Now I want you to imagine, again, sympathetic nervous system as an example. Now imagine if you were, if someone were just resting, okay, and I'm just as hypothetical, just imagine if they had like a beta-1 receptor and it were half inactive, half active. Maybe their heart rate would be 70 to 80, something like that. And even though we always have a little bit of norepinephrine or epinephrine, just imagine we're starting with low or no, okay? And then all of a sudden, like, you start exercising and you start releasing epinephrine and norepinephrine, which would really be full agonists. They only prefer the active conformation. Okay, so they're going to shift the equilibrium to the right. But then, okay, so what if this person, in a real example, what if someone's heart rate is always too high because they always have too much adrenaline for some reason? It could be a tumor that releases it, which really does happen from time to time, or anxiety. So how do we decrease the heart rate? Of course, you're going to give an inhibitor, but what kind of inhibitor? In many cases, we'd give a standard antagonist, right? And they're still trying to figure this out. So which drugs are standard antagonists, which ones are inverse. In some cases it's relevant, some cases they don't need to, but the whole point is that if you look again the middle panel, the unoccupied receptor we said is at we said it's at 50%, 50%, 50%, 50%, right? So in both cases the unoccupied receptor should not change. It should still be 50% active, 50% inactive. Okay, if you're just looking at the one that's not bound to the drug, it's 1-to-1, right? But what we've done with the drug with the adrenaline is shifted it to mostly active, 80% active. However, if we give the antagonist, we can pull it back to the left a little bit. And notice in this example, I still have half and half, 50-50 unoccupied receptor, be active or inactive. So it'd be a ratio about 50-50. But we've occupied some of these receptors with antagonists, so we've trapped them closer to their equilibrium, right? We've trapped some inactive and some active, rather than most of them active. So the whole point is that, even if you don't understand every detail about every type of antagonist or agonist, you should understand that you can shift that percent active receptor, you can shift it in different directions depending on what you're adding, right? If you're adding an antagonist to an agonist, you shift it to the left. If you're adding an agonist to an antagonist, you shift it to the right. In a rare example, if you had an inverse agonist and then you added an antagonist, you would still shift it to the right because you'd be less inactive in that case, right? So, but this slide is really showing you what would actually happen, right, if you're giving like a beta blocker like propranolol. It's not going to inhibit every receptor, but it's going to shift you closer to your normal receptor population, which would be closer to this 80 beats per minute rather than the 150. Finally, allosteric antagonists. They're just like the agonists, but they do the opposite. They still bind to a site on the receptor that's different from the normal agonist binding site, but they would decrease the affinity or efficacy rather than increase it. Okay, so the agonist alone might look like that. If I have an allosteric antagonist, maybe I interfere with the binding site, so it still has some affinity, but not a lot, right? It's kind of weak, a weak bond. So that would show up or manifest as, a reduced response to that agonist, right? For every molecule at agonist, you'd have a reduced response compared to normal. So this is the chart of an allosteric antagonist specifically that just affects the affinity of the agonist. And remember, I said any antagonist at all should shift the curve to the right, but if we're only affecting affinity, we should be able to still achieve, for the most part, the same maximum biological response as long as we can increase the dose of the agonist enough, or the concentration of the agonist enough. So these red lines mean, lowest amount of antagonist, then higher, and the highest amount of allosteric antagonist should shift the curve to the right, but still give us the same biological response, maximum biological response, if we're just affecting the affinity. Okay. However, if we're affecting efficacy, the curve will look different, and that's what I'm going to show you after this slide. So this slide is showing you, just like a cartoon of what would it look like if an allosteric antagonist did not change affinity, but it did change the efficacy. So why would that happen, or how would that happen? So quick animation. So agonist alone looks the same as before, and what this spike was supposed to indicate that something happened inside the cell. If the membrane were here, some biological response. Okay, so something is happening. Vasoconstriction, calcium influx, cell division, anything is happening here. But if we have an allosteric antagonist that only affects efficacy but not affinity, the binding site should not change, right? Because we're not changing affinity. No change in binding site. But what does this mean? And all I'm trying to say is that this is weak, right? The biological activity is weaker even though the drug bound with the same affinity, had the same binding site. This guy threw a wrench in the system. This allosteric, the allosteric antagonist, it didn't change the structure of the binding site, but it changed the activity or conformational change inside the cell that triggered the signaling cascade. It made that weaker, right? So the drug can still bind, but the response is filtered or different. And right, it's very much slower, much weaker biological activity. So the efficacy has changed. On a graph, yes, that in many cases will show a reduction in the maximum achievable biological response. Now it depends on the dose, right? If you have a low enough dose, maybe you could, if you're not occupying all the receptors or enough of them, you might still achieve that maximum biological response. But in many cases, you will lower it, which is going to make it look different than an allosteric antagonist that only affects affinity, right? One that affects efficacy is going to look a little different. It's going to drop it lower. So that actually wrapped up the discussion on agonists and antagonists. And this last piece, these last few slides are actually very different, and it's something that you don't really talk about much in the other courses, but it is something important to understand. And I think several faculty will probably allude to it. This drug has a low therapeutic index or a narrow therapeutic window. This is maybe the first time you're going to hear the actual definition of that, and then in the curriculum you'll hear it several more times being used. But the therapeutic index of a drug is an estimate of the drug's margin of safety. The components of that, it's a very simple equation. The components are the effective dose and the lethal dose. And of course, they're not going to measure the lethal dose in a human, but they would do that usually in an animal model, rodent model, for example. The effective dose estimates the drug's effectiveness. By definition, that's the dose of the drug that produces or protects 50% of the population studied, or we'll say the dose that produces the desired therapeutic response in 50% of the population studied. That's the ED50. The lethal dose is the dose of drug that kills 50% of the population studied. That's the LD50. The equation is LD50 over ED50. So if you look at that equation, you'll see that the lethal dose is on top. The lethal dose the dose that is lethal to 50% of the population. So that means that the higher the LD50, the better. I hope that makes sense and is intuitive, right? So the higher the lethal dose, the better it is, because that means it takes a lot of drug to harm the patient. Right? So the lower the effective dose, the better. And really, more importantly, the ratio is the most important thing, right? So the higher this ratio, that means the more different the LD50 and the ED50 are, and the better. So we really want a high therapeutic index. Okay, the larger the ratio, the safer the drug. So example is phenobarbital. That is a sedative. Sometimes actually, barbiturates can be used to induce a coma. Actually, if someone had any kind of brain or head trauma, the therapeutic index is about 10. That's really not great. It's nowhere near as good as like an antibiotic, but it's okay. On the other hand, cardiac glycosides, such as digoxin, used for controlling heart rate or for heart failure, has a very low therapeutic index, so it's very easy to overdose on that and cause toxicity. Okay, so that's really important to understand. The lower the therapeutic index, the more dangerous. The higher the therapeutic index, the safer the drug. We have kind of a more mild version of this called the protective index, which instead of lethal dose, it looks at the dose that produces toxicity in 50% of the population. So the TD50 over ED50. In this case, you have to define. So what toxicity are you discussing, or are you analyzing? So is it, is it a side effect that's mild, like nausea? Is it a side effect that's severe, like cognitive dysfunction? Or you have to define what toxic response you're looking at, and of course what effective response you're looking for, which might be for phenobarbital, maybe reduction of seizures. So the same thing holds true, though. The higher the protective index, the safer the drug with respect to side effects, not necessarily the lethality, because that's the LD50. That is the therapeutic index, right? So it's different. So this concludes section 3. I have one more section from my material. That'd be section 4, and that is going to be signal transduction. That is actually the shortest section. So thank you for listening.